So the topic today is hypoxic ischemic encephalopathy, and this is I don't want to say this is near and dear to my heart, but something I landed up in earlier in my career, and I will show you the slide. How early was that? So it's a suspense. So be there with me. So anyway, this is the disclosure. I have nothing to disclose. This will be a CME presentation for fellows. These are the outlines I'm going to talk about today. So let's start. The first thing I want to mention, especially for fellows, that HIE is only one type of encephalopathy. So there are you can categorize into stroke, you can categorize into infection related or brain damage. So HIE is just one part of total neonatal encephalopathy. So it's not synonymous. You cannot just say HIE and neonatal encephalopathy. Okay, so and if somebody, I don't know those who are here in last 6-7 months, there was a case we have a HIE with high serum ammonia. So encephalopathy comes in different shapes and sizes. So what is HIE? So as the name suggests, hypoxic ischemic encephalopathy. So it's a brain dysfunction that results because of decreased oxygen and flow and ultimately causing damage to the brain. So the pathophysiology. So keep looking on the two pictures and you will see some animation going on the picture on the right of the screen. And you guys can see the color of the baby that is taken from, internet. It's a nice picture, which already shows that there is some compromise going on the other side of the baby. So see this thing now, that how the placenta supplies. So any accident in the cord or placenta can give rise to decreased blood flow to the brain, which ultimately leads to the whole cascade of HIE. So I'm going to show you 4 or 5 slides on the same topic, or the same thing. The idea is marketing. If you see Coke on so many boards, you will buy Coke. If you see Coke means Coca-Cola, okay? Don't take Coke in the other way. Or if you see any advertisement, so just those who are pictorial learner, trust me, these are all different format. One is horizontal, one is lateral. We are talking about the same thing. So anyway, let me walk you through. So what happened when they sell, there is decreased blood supply. Of course, the oxygen is not there. The body goes into anaerobic metabolism and the whole cascade starts. So one picture. This is the second picture. Talking on the same. Let me just show you with the arrow. So see, decreased blood flow, then decreased oxygen, then anaerobic metabolism, the production goes down. Then of course, reperfusion injury happens. So this is for the horizontal learner people. Now the other one, for again the vertical learner, same thing I'm doing in a different pictures. But the whole idea for you guys to understand that is the cascade. And the earlier you intervene, see the window of therapeutic window is there, we will talk about it. Same thing here, the primary energy failure happens and then ultimately and these slides are available for your view later on. The advantage of technology, now you have video, so you can pause and look into that. So something I want to talk about that how neonatal encephalopathy is dependent upon placenta. So this is a nice article. If you guys have time, like I said, pull this article and read. So they talk about 4 types of pathology in the placenta causing different, encephalopathy in the babies. And if you guys can recall that chorioamnionitis has been associated with cerebral palsy. So the reason is the same, the damage which happens. So now clinical manifestation. This is the real part which we clinicians see because, like I said, pathophysiology is just to cover the topic. So one has to know what is SUNAT and CERNAT classification of HIE, and I have a small mnemonic on the right side of the screen, CAP-TAP. So if you remember it. Sure. Yeah, basically what they say, as you can read through that, if there is some malperfusion, then you will have these associations. If you have vascular malperfusion on the fetal side, they talk about maternal side, fetal side, and all that. And these are the different pathology findings. So the point which I want to make, especially from the HIE perspective, is just focus on the delivery, but things could start earlier as well. So there is placental component to HIE as well. That is very reassuring for our OB colleagues to know, because it's not only the time of delivery. And I'm going to touch base again. Like I said, I'll repeat my presentation and the talk that it could be intrapartum. You can have a problem. It's not just partum or postpartum. It could start early as well. And like I said, I have interest in it early in my career. So I looked at nucleated RBC. I did a lot of work in that. Unfortunately, never get into, it never boils down to a publication. But anyway, so answer to Dr. Mahana's question is like the whole idea about this slide is that it's not only the delivery. Things could have started earlier. So again, going back to the clinical presentation, and just remember this slide I'm going to touch again, because when I'm going to talk about when to put babies on hypothermia, I'm going to talk about that again. So this is the cascade which I was talking about. That things start with one, and then you see how everything is interlinked. Unfortunately, once the whole cascade is started, and baby goes into primary energy failure, and then secondary energy failure is some multi-organ problem. That's the problem with HIE. It's not like you have one problem. Like the other day, we talk about oxygen in the lung or pneumonia or IVH. Is this problem is unfortunately is global. What investigation we can do? Clinical exam or clinical history is very important, honestly. You don't have to investigate. It's not like a 70-year-old who come with stroke and now you have to find out what's going on. The advantage with neonatology, the history is very limited. Maternal history is basically your past medical history. So anyway, investigation are needed again, because just to diagnose and go further. So a CBC can tell you about anemia, or if the bleeding is there, hematocrit is low, the cause is probably something, but you will probably know beforehand. The OB will tell you. CMP is not really part of the diagnosis. It's part because we put the babies on hypothermia. And on the right side, I have put the insert from our order set. So the order set automatically has all these investigations. So I'm not touching about you're diagnosing it. I'm just saying that you already have that HI, you're putting on what to take. It's a practical side of it. What investigation you should check. Great part about Epic is it already gives you order set. So you basically check everything. And again, of course, head ultrasound has been a part of it. Earlier in the 90s, when things started, ultrasound was not the part of the investigation, but it is now. And I'm going to again tell you when and how we do the MRI. So again, the many markers are there. These are again not very specific as any markers are, but I just wanted to give you this slide, and there is a barcode. Like I said, you can pause the slide and then. So what about getting encephalogram? When I came out of the fellowship, I went to a program which they have amplitude integrated EEG. So I was very lucky. The nurses taught me how to do it. It's a toothbrush thing. You put it in 3 spots. I used to do it on my own. But here we are further lucky that we have 24-hour EEG. So which is better, of course, the 24-hour video EEG is much, much better than amplitude because it's only 3 lead. And I'm going to tell you again how the differences between the two. So this is the picture you get on amplitude EEG, and there are different patterns. Of course, remember the lower the voltage, common sense that things are not really going through the brain activity. So you want somewhere around 5 to 5. The first, let me show you. So the first bar which you are seeing is what you want to see. There should be continuous normal voltage change. If it's like really at the extreme, that's not good. And we don't have it, so I'm not going to do more on this because, if you end up with other program and they do it, it's very easy to do. It's very easy to really have it there. So this is what we have. And in comparison, if you see the normal side, and on the other side, you see the abnormal side. With burst suppression, as the name suggests, you have burst off and then you have suppression. Burst and then suppression, as compared to normal. And you guys know about alpha, beta, theta waves. So the delta is the slowest, and the beta is the when awake. So these are the things, but this is not for this talk. But what I'm going to say that EEG, if you have the facility of video EEG, get that. This is a very nice presentation, I think, from Great Ormond Street, UK. I watched the whole video. Fantastic talk. It's like 20 minutes. You can watch in a high speed. Honestly, you learn a lot about neonatal EEG from this talk if you guys have time. So next is imaging. Like I said, imaging is the part. Like I said, head ultrasound, we should do it before putting the baby on some hypothermia treatment. But imaging means basically MRI should be the part which should be doing. So there are certain pattern of HIE depending upon the pathology. If it's a global damage, unfortunately, you will have global damage manifested. If it's a watershed area, those areas where the blood supplies, merges and they don't have like the main territory supplying it. And then you have different pattern. But the main idea about this is to walk through to this slide. This is very important. This is from NICD SEH that, they have a score. So basically, if you just put the arrow here and you see 2B, which means basal ganglia. And so common sense, the more damage is done, of course, the outcome is more compromised. So what you can say, family is asking you, and if you see that this is stage A, you can say the outcome is being related, but this is a very nice way they have, you can pull this article from 2015. to learn more about. But this is something which honestly I didn't know earlier in my career, that you can even grade it based on the MRI. So the management, thanks to Ariana, she wanted me to spend some more time on management. My earlier slides doesn't have much, but this time I have included few things. So this is my journey, which I said I'll share to you. See the year in 1999, just after post fellowship, I was so excited. My first paper got accepted and published on pediatrics. And the story is very funny because I did that and I have a break in my fellowship. So when I came back after 8 years, my program director was talking about hypothermia and she showed this slide. She said, my fellow is sitting there and he has written a paper on pediatrics. It was really nice to see, but it's not a great paper, honestly. It's just this paper was rejected from seven local journals and got accepted in pediatrics. Idea is don't lose hope. Anyway, so hypothermia is the management. And this is again the history, like I talked to you about, that how it started. Then, of course, now it's a standard of practice. Management. So again, delivery room. The thing is, most of the time, you will know what you are facing. But like, those who go to a smaller rural areas for their waivers or other problem, trust me, sometimes you don't know. It's like a really just rushing in and you don't have. We are lucky here because most of the time we know it. They call us non-reassuring heart rate. You know what you are dealing with. Many times you don't know what you're dealing with. Cord around the neck could be a possibility. Assisted delivery, any history which is suggesting prolonged second stage, you're going to deal with shoulder dystocia. They're already working at. For us, neonatologists, if we are standing there and our OB colleagues are taking longer time, our heart rate goes up. Fetal heart rate goes down and our heart rate goes up because we know what we're going to deal with. And of course, surprises are surprises. There's a debate on warmer on or off in these cases, because most of the time you can resuscitate and baby is going to do okay. You might not need hypothermia. But suppose if you know that there is already flat strip or sinusoidal rhythm on the fetal heart rate, it's better to start passive, which is really interesting. But how can you gauge before you get the baby? You cannot just decide that. So I'll show you. I have questioned it with the NRP and I hope they will answer something, which I will show you. And again, second thing is also, I think Komal has asked earlier in one of the presentation, a great question that when should we do our first SARNet exam? Should we do in the delivery room? Should we do the exam in nursery and ICU? It's again, it depends upon the practice which you guys do. No, you're right. Actually, I'm going to talk about how to do it. But like I said, it depends upon the case scenario, which area you're working is level 2, level 3, what you're only one. So ideally, like Dr. Mahana said, the earlier the better, but there's a catch to it. If you do it early and you make a decision and by the time baby reaches the nursery, so that's why periodic examination is more important than one examination because exam can change. And that's why people don't jump on the first exam and start hypothermia. And we have faced it many times in our clinical practice. And I have some cases, really. We'll walk you through. I'm a clinician. I'm not a researcher. So I go with clinical cases and we'll. No, it's okay.
That protocol becomes the standard. At that outcome. And they have it's written, it's what's published in pediatrics. It was a beautiful paper. That's where the protocol came from.
No, what
was tested.
Let me
But
clarify.
there is but there's definitely many other papers that contested that timing. And at the PAS meeting last year, there were papers looking at repeating that SARNet exam at 1 hour, at 2 hours, and they identified qualified if they were not, or disqualified if they were followed on that. So there's literature on it. And that's, you gotta talk about it.
Yeah, and trust me, I'll show you. I have a nice presentation of that, nice slide on that. Anyway, so two things, hot gas and Apgar score. So this is like you already have a, let's go a clinical case. You have a baby, you're expecting non-assuring heart rate, the baby delivers. Now the cord gas is sent. You don't know about the cord gas. You have the Apgar in your hand. You are resuscitating. 10-minute Apgar is 3. You know this baby will need that. You call your attending, or if you are the attending, you know that this baby is going to go for hypothermia. You do your examination, the baby is moderate. You call the unit, please set it up. We are bringing it. It's easy peasy, not a debate. The problem is in borderline cases. The ABGA, there was nothing told by the nurse, by the OB, the baby delivered. So you low heart rate, you started resuscitating 3-4 minutes down the road, the heart rate comes up. Then you take the baby to the NICU because you resuscitated. The baby is now perked up. The cord gas came at 6.9. Now you are in a dilemma. Should I pull the baby? My exam is normal. So that's what I'm going to talk about. And there's a lot of literature, like Dr. Mahana said. So it's not an easy call, honestly. Clinically, it's much easier to stand here and teach HIE. But when you are put on the spot, it's not very easy. Just like NAC, necrotizing enterocolitis. No expert with 30 years of experience cannot come put down and say, yeah, this is NAC. This is unfortunately the problem in NICU. Your experience does not count that much because things changes and it's such a variable presentation of a disease that you just don't know, honestly. Anyway, we'll talk about it. So now the question about this passive cooling, which I said that should I put the warmer on if I already know that I'm going to do that. So there are two articles. Again, pause the slide when you watch it on the video, or you can take a screenshot to look at that. So this is the article. I think this was from somewhere from Europe, where they based this passive cooling on. And this is the question I posed in the, because I'm an instructor, so you have access to all that resources. So I posed this question that what should we do in that cases? Because now, like I was telling them this morning, that NRP has a cardiac course now attached to it. So you pay $25, you get separate cardiac course, which is very interesting. So it's something I posed. So let's see what they answer. Nobody knows about what to do if you already know that this is going to be a hypothermia day. Again, you remember this slide I shared earlier, multifactorial problems. So you really basically have to, my attending used to say, Shabi, if you have taken care of NHI, you know neonatology already. You know all the pathophysiology. Fortunately or unfortunately, we don't read much of pollen fogs and physiology. When we were fellows, this was presented to us in first year. But now, thanks to YouTube, thanks to other channels, you don't need to read all that. But just remember, it's a multifactorial. You cannot just work on one organ and say, I'm fixing the baby. There are a lot of things going on at one time. So again, same thing, like I said, I will just say that how the things are changing with time, you just have to really gauge it. That's why you have to be at the bedside. And again, recently I found this very interesting that even keeping glucose in normal level has been associated with, long-term outcome. This morning, somebody associated the hemoglobin A1C in neonates with ROP. So people were writing in the comment, are you crazy? What is this association? But there's a full article, somebody looked at hemoglobin A1C in neonates. First, they validated that, then ROP. But these are association. What I'm saying is very difficult to prove the point, but this is something to look for. And renal function test, again, one thing which I have learned, if a baby with HIE is having good urine output, trust me, you're rest assured, thank God the kidney is not hit. If liver enzymes are okay, because a multi-organ thing, having a good urine output makes your night go nice. If you don't have urine output, then oh my God, that the horse is already outside the barn. So again, the definition of AKI, again, like I said, I don't have to go through again. This is all about that. There are definitions. Interestingly, I went to Houston for a dinner and I saw this. AKI Steakhouse and Sushi. I said, I don't know what AKI Steakhouse and Sushi, but I just wanted to tell you guys that there is something you have to. So again, there are many controversies that Dr. Mahana pointed out. Like at what point, like if a baby with 6.9 pH, should I use bicarb? Should I don't use? Like I said, early in my career, bicarb was the thing to go. But then somebody wrote an article and they looked at it, bicarb was looked, in a critical way. But my thing is, if you don't bring the pH up, the organ are going to fail further. So I am biased to give it, but the literature unfortunately does not support it, as I highlighted the marker. So it's your call. If it's 7.1, I'm okay, but it's 6.9 persistently, I think we should have to do something. But again, I'm just quoting you the literature, you decide. Same thing on the nutrition. Some people feed the baby. I have this traditional training that babies with gut perfusion injury, You know what dive reflex is? Anybody know what dive reflex is? So when you have dive reflex, your perfusion to this splenic areas goes away, and this baby already has gone through, all that reperfusion. Should I feed that gut? So I was trained not to feed, but things are changing. Again, I'm just posing you the article, you decide. So now coming back to what Dr. Mahana said, that every institution should have their own protocol. Fortunately, most of the units do follow the same protocol. Recently, one neonatologist was really questioned because he put the baby, a 35 weeker, on HI, and unfortunately that baby died. So poor guy was almost put to the court that why it was not the hospital protocol. He said it was just 35 weeks, it's by 1 week. He said, no, you should not have put that. It's not our protocol. So anyways, I don't want to share the whole story of this guy because this video will be online and he will be looking at it. But I just want to say that please do follow your protocol. That's what the conclusion is. Follow your institutional protocol. And I will talk to you that there is room to do that. But how people look at your decision, if the outcome is not good, unfortunately, then you'll be questioned with everything you have done. So anyway, this is our protocol. And this is thanks to our fellows, like what Dr. Mahana mentioned earlier, that you don't treat either the cord gas or you don't treat, APGAR. You treat a clinical scenario, that's why I'm trying to say that Sarnat exam is so important. That's why fellows developed that what was happening, that we were getting a lot of call that cord pH is 7.00. What should we do? Should we admit the baby to NICU? So they have come with this protocol. And again, like I said, my idea is not to walk through. I'm just telling you how HIE and all that and cord gas has evolved. I think we are learning still, but we are not there. And there's an app, of course, you have an app for everything. I'm flying next week for a conference, and today Delta sent me that you have to download an app because that will be easier to access. God, how many apps? I have like 5 pages already of app on my, so everything is app now. But again, they have a disclaimer. This is just to support. You should not make a decision basing on this app. So you put some parameters, it will spit out the decision plan, but it's your responsibility. So this is what hypothermia does. It basically cools off the things for the time being. Just like when you have argument with your wife, you just want to cool down hypothermia for 6 hours and then no reperfusion. So these are the complications you have, which is known. So my paper, which I wrote in pediatrics, I pick on the bleeding side, and we have few cases, and I question it. It was a dog experiment they did somewhere. So that's how I took the paper. So anyway, you have to know the complications. This is a very important slide which Dr. Mahana pointed out. There's so much controversy with HIE. So whenever we have a case of HIE, my teaching is honestly, if you're in doubt, just put the baby on hypothermia. You can fight later, but this guy, unfortunately, which I quoted you, cannot fight. But again, these are 5 controversies. So let's go one by one. So first one is there are studies that in low income group and middle income group, the outcomes are different. So should we use it? Their protocols are different. Second is, should we do less than 36 weeks? Again, data is there. People are trying. Third one is, should we do it for mild hypothermia? Like I said, sometimes we do it. It's a soft call, and we say, no, baby just perked up. The moment we are arranging for hypothermia, the baby's crying top of the lung, extubated, repeat gas is 7.38, but I have already started it. So what can I do? So again, there is literature, and I'm going to touch base on that. The fourth one is, why not we can do it? Although remember the slide where I said reperfusion injury, you still have time. So they looked at why only 6 hours. Can we? And sometimes we do. If the baby, you decided not to do because there was no seizure, everything is fine. 7 hours of life, baby started with seizures. So again, these are controversial things, but thank God there's literature, so nobody can put you down on that. The last one, somebody thought, why only do for 3 days? Why can't we extend it? Or why not go further deeper? Instead of stopping at 33, why not go 32? So that's how scientific people think. But again, like I said, all are controversial. And if you are interested, this is the article. Take a screenshot or whatever, watch it later. But if you want to read more, but it's still controversial. I have no answer which one is better than other. Sorry. No, please. That's the whole purpose.
They
Right.
down. By the NICHD. The deeper and longer actually is showing force. So it shouldn't be controversial anymore today. It's worse if you go below 33.5, there's a higher mortality. If you go beyond 3 days, it's higher. So this is the, this may be controversial studies,
Right, exactly.
but now it's,
And that's what the article talks about. Like I said, the blab I have or the line I have controversial because for the same reason that I'm just throwing the idea that how one thing which is right at now could not be right. So what should we do as a clinician? Our dilemma is like, if I was at that time, what should I have done? Like same example, 8-hour-old, the baby has seizure. What should I do? Now I know the answer, but that time I didn't know. So people have questioned that. And that's how these review articles, they discuss the whole history. It's like a 12, 13-page article. So I just browse through it and I'll just throw the idea and you guys decide. So neurodevelopmental outcome, again, talking on the same token what Dr. Mahana said, I'm just going to show you a few slides and you will laugh at it at the end. That how the developmental outcome, this is from Japan. Look at the mild, severe, whatever you want to make. Then from, see, of course, the more severe the disease, it's no rocket science. The baby is going to do worse or not better. This is from Ireland. I'm not going to read through it. I'm just showing you. This is from Sweden. This is from US. This is from Italy, and different outcomes. What Dr. Mahana said, one group at the same time is saying do this, the other group at the same time is saying it's no good. I'm in dilemma. What should I do if I lead literature? If I follow one protocol, like this guy, 35 weeker would be saved if he has said this is not my unit protocol. That's it. But he probably followed some new research and now this guy's in trouble. So real world, again, like I said, spirit, if you see, they said there's no benefit in my, what I'm going to follow? Like really, it's very difficult. So this is the conclusion. You will create a dog into a tiger with this thing if you follow all the studies. Really, you will not have a clear picture. Honestly, it's very, very difficult with HIE. You can choose anything. Nobody can prove you wrong if you have a basis for it. Anyway, so this was an interesting slide as for Instagram that how research paper after so many revision brings like this. And your whole initial thought process is all gone. Anyway, so there are some biomarkers that can help you in deciding. And again, like I said, I'm not going to walk you through everything, but some are for researchers. This is a nice one, and I try to, dig more into that, wrote a letter to editor to the article, and then they question it. But anyway, there are many markers. So I just wanted to show you this is something recent. So suppose we don't have hypothermia. There was time when there was no hypothermia. So people must be doing something to prevent these babies from getting these or bad neurodevelopmental outcomes. So erythropoietin is something which we were thinking it would be promising. So, but the study came and there's like, unfortunately, nothing again. So we are again back to hypothermia as the front line. So we still have no medication, but there are certain things people have tried. Xenon, argon, these are the different things people have tried, and they all have different pathophysiology acting at different area. The whole idea is how can you prevent this from happening further? The damages already have been started. Where you can block the cascade, and maybe among you, somebody sitting there who can invent a drug which can block something, and then you prevent. I don't know. It's a possibility. Again, this is a slide from a paper that how different things act. Like I said, you can pause this and later read on. And again, people are going back to that. Maybe it's not. Maybe this baby, unfortunately, is destined to be that. There's some genetic component to HI rather than, the event itself. Going back to the same thing that things could start early. So they're talking about all the omics, genomics, epinomics, whatever you could think of. So what is the roadmap? This is what I was telling you early that, sometimes it can start early, but you just have to make sure that your part as a neonatologist starts when the baby is born. You should know the pathophysiology. You should know your hypothermia protocol of the unit. You should know where to activate, whom to call, when to get an ultrasound and all that. So again, some keywords. So this is the case. So through examples, I'm going to give you. And again, I'm not going to read through that. So just the red parts are important that this baby is delivered with a tight nuchal cord. So you're expecting something, no abruption. Apgar was 5 and 8. The cord gas was 7.2. The other one was 7.3. So arterial venous difference was also not that great. But look at this. This baby is progressing. The arterial gas on this baby is 7.07. This is postnatal. But in this case, hypothermia was initiated because baby was acting wrong. So this is an example where it was borderline case to start with. Cord gases were not bad. but a decision was made because the clinical exam changed over within the time frame. So this is again very important because there was a case we debated few years back. The note from the trainee people was very different, gag reflex and all that reflex, and we said why we did not did the hypothermia. So you have to have a very structured exam. You cannot just do the gag reflex, corneal reflex, and all. Just follow the CAP tap, which is conscious level activity, posture, tone. Just 6 things we need. Out of 6, if 3 are there, the baby qualifies. Simple as that. Please don't do all that. Hypertonia, gag reflex, corneal, rooting, knee, clonus, Babinski's. Don't do all the neuro exam. It's so easy. Just follow SARTAN. So now the other case. In this case, the cord pH is bad, 6.98. And so now what should we do? There was no history. That car was all good. So here comes this protocol. Before our fellow adopted that, somebody has done a study, a quality study, QI study in California, and they decreased their admission just based on this protocol. So science is, which I was telling you, the QI, when you review QIs, this is the idea beyond doing the QIs. You want to make it better. So they were sending every baby to NICU. They said, what, stop that. Just teach the staff good SARNET exam, show them the video, make it structured. But Dr. Mahan is saying, everybody should be doing SARNET exam at a particular time. Do it periodic exam so that you prevent. And this is really self-explanatory. This is almost the same Komal which you guys have. So this is the one, basically that's. So full idea about this is, see the 2 cases. One case you wait, but you make a decision. Second one, there was no history. You can follow this and save the baby from unnecessary hypothermia. So 2 part in the circles, and this is the fellow's work on the right side. So basically, cord gas is the one component. The other is clinical exam. If I have to choose, honestly, I will go with my clinical exam because cord gas is just reflecting the time, what happened to the baby at that time when you got the cord gas. It's just a snapshot or maybe few minutes before that. But my exam, if I resuscitate well, baby responds well, I don't have to treat the cord gas. I have to treat the baby. And again, like I showed you in many slides, that just doing hypothermia is not the solution. It's cost. There's cost attached to hypothermia. So if I come, if God is good, I'm your attending, I said, put on hypothermia. I want it. Yeah, but sir, you have to have certain criteria. You cannot just use, you are a physician, you can prescribe anything under the world, but you should not. That's why you guys know Choose Wisely initiative that in internal medicine, they follow it even in pediatrics. Bronchiolitis management has changed. The fall and CT, doing all that has changed because you have to choose wisely. You should not be doing CT scan of everyone. So same thing with hypothermia. Don't put everybody, if you want to do it, just to prevent. But again, it's very easy said on this podium rather than when you are on a spot. It's very difficult. So again, you guys know all this for 2x2 table that we want high value care. High value care is where the treatment was really needed and you did it. There are scenarios, unfortunately, where the treatment was neither indicated, but people did. And there are cases, you see unfortunate cases with hypothermia. Why you started? Apgar was good. Oh, because my attending called and they wanted to put the baby on hypothermia. For what? So that's why we have QI review committees to look into that. Remember always cost and quality. They go hand in hand. So this is again like my quest, which started in 1999, is still going on. I still review papers, still write some comments. And this is another one in British Journal. And this is one which we wrote. The case, remember I told you that there was a case, the treatment was started and half of us thought it was not indicated. So we wrote this article that to cool or not to cool, and then we debated it. It was a nice one and it got published. So again, I'm leaving you with more questions than more answers. But you guys know sometimes questions are more important than answers. And trust me, if you ask me, I'm not an expert in HIE. If clinically I feel that baby has moderate HIE, I will treat them. And later on, let the scientists decide, oh, you over-treated it. But mild, that's a difficult call to make, honestly, because most of the literature says that there's no difference in the outcome. But who will say mild? Maybe my next exam, this baby is moderate. So I don't know.